Hello and welcome to Home is Where the Heart Is, a free webinar presentation to introduce the Home Health Quality Improvement National Campaign's new Cardiovascular Health Improvement Initiative. We're so pleased that so many of you have joined us for today's live webinar broadcast. And to start things off, we'd like to have a welcome message from Cynthia Pammon, who is the lead for the Million Hearts and Disparities programs and the government task leader for the Home Health Quality Improvement National Campaign and Advancing Excellence National Campaigns with the Center for Clinical Standards and Quality Improvement Group at the Centers for Medicare and Medicaid Services, or CMS. Cynthia?
Thanks, Shannon. Hello, everyone. On behalf of the leadership team at CMS, I want to extend a heartfelt welcome to you and thank you for participating today. The integration of cardiovascular health care improvement into home health and alignment with Million Hearts, a major Department of Health and Human Services initiative, is long overdue. We will support you in this work by giving you access to best practices and other resources to help prevent heart attacks and strokes in the home health population. We at CMS are so excited to begin this journey with you. So without further delay, I want to turn the mic back over to Janet Wright, and I hope you enjoy the webinar today.
Thank you so much, Cynthia. And for today's webinar, we're going to hear from a whole wealth of different speakers, starting off with a keynote address from Dr. Janet Wright, the Executive Director of the Million Hearts Initiative. That'll be followed up with a specific presentation on some of the cardiovascular educational resources that we at the HHQI National Campaign will be offering, and that presentation will feature Eslinger. We'll also talk about ways that you'll be able to measure your cardiovascular improvement with Cindy Sun and focus on cardiovascular resources for underserved populations with our own Misty Kevich of the HHQI National Campaign. Finally, at the end, we'll have plenty of time for questions and answers, and you can start sending your questions at any time. Just simply type them in an email to hhqi@wvmi.org, and then we will get to as many questions as time allows during today's webinar broadcast. So that's what we have in store for today, and at this point, I'm going to toss things over to Dr. Janet Wright for today's keynote presentation.
Hello, everyone. It's a delight for me to join you today. I am particularly excited because I know that home health agency staff can make the difference in blood pressure control for the country. I realize that's a lot of pressure, but I know you all can deliver such an important outcome for the patients that you care for. So let me introduce you to Million Hearts. As you see here, Million Hearts is a program started by the federal government, but really executed by a set of partners across states and into the private sector. The goal for Million Hearts is explicit. It is to prevent 1 million heart attacks and strokes by 2017. The initiative is co-led by the Centers for Disease Control and Prevention and the Centers for Medicare and Medicaid Services. And the idea there is to bring together the brilliance around science and population health and community that exists at CDC and marry it to the powerful payment and policy levers that exist at CMS. And as I mentioned, the work is really being done both across federal and state governments, but out into the private organizations and really all the way into the homes where we live. So let's look at the framework for Million Hearts and really examine why the government would get interested in one particular condition. And the reason, of course, is well known. Cardiovascular disease continues to claim 1 out of every 3 deaths in the country. More than 2 million heart attacks and strokes each year and over 800,000 deaths. It's traumatic, of course, and we lose family members and people with whom we work. It is also costly for the country. You see here over $1 billion, almost $1 billion a day in healthcare costs and lost productivity. The other reason for us to focus on this is that cardiovascular disease is the #1 cause of health disparities. African Americans, for example, lose 14 months of their life expectancy to cardiovascular disease. It's more than twice causes of other reduced life expectancy. So we have every reason to attend to this one medical condition. Another reason we focus on cardiovascular disease is that we know what works to prevent heart attacks and strokes. And the 4 elements here that we call the ABCs, ABCS, are actually those pathways to prevention of heart attack and stroke. Aspirin for those at risk, that's secondary prevention. Blood pressure control, not just measurement, but actually controlling the number, less than 140 over 90. Cholesterol management, and smoking cessation. And the statistics you see here are those at the population level for Americans. Just globally, when you look at that, you can see we're not even getting to 50% performance for any of these relatively straightforward interventions: aspirin, blood pressure control, cholesterol management, and smoking cessation. The number that bothers me the most here is the smoking one, because the denominator are those people who've already decided to stop smoking, and only 23% of them are receiving the pharmacotherapy and the behavioral counseling that can help them quit. So we have a very high burden condition for the country. It strikes all of our families in one way or another. It's very expensive, and we're underperforming despite having medications and lifestyle interventions that are very effective. So it's time to focus on this and change the performance. So I'll enter in now the structure of Million Hearts. And what you see here are 2 lanes of traffic, if you will. One set of activities focusing on getting excellent in those ABCs. Those efforts are really targeted at healthcare professionals like yourselves and the systems in which all of us work. Over on the right column, under Keeping Us Healthy, are efforts that are aimed more at the population and the community, so that the healthy choice is the default. I'll kind of walk through each of these, and we'll start over on the right side with the community-based interventions. But before I go there, I want to say that when it comes to minority health, we in Million Hearts have an extra special focus on those who are hit the hardest by cardiovascular disease. I'll focus a little bit on some of our activities in that area. We believe that's the bridge that brings these 2 together. So I'll bounce through a couple of thoughts. The first on the population side is that we can make a tremendous advance in health and preventive events by gradually reducing sodium in the food supply. And the efforts there are really undertaken by CDC and FDA and others, working with the food industry to make more lower sodium choices available. What this slide shows is that what we add at the table and in the kitchen does not make very much difference in the overall sodium consumption. Most of us, and 90% of us, get in more salt each day than we should, but most of us get our salt from processed and restaurant foods. So working with the food industry and the restaurant industry to gradually increase the availability of tasty and attractive lower sodium choices will make a great impact on the overall sodium intake of the population. This slide shows me that on trans fat regulation and reducing the trans fat in the food supply, we have a lot of gray areas left in the country. The gray areas are where there's not much going on in terms of regulation of food service establishments. We've got some high spots in pockets that are colored red where good regulations are already in place, but we have room to grow there. I'll flip over to the key components on the clinical side now. How can we go about creating excellence in the ABCs? And the first, as you see here, is under prioritizing the ABCs, how to get excellent there. We believe that the use of registries within electronic health records is one way to achieve that, to develop point-of-care reminders so that as you see patients, you get an actionable step, a reminder that lets you know that that individual perhaps has not had a recent cholesterol check, or has had a couple of blood pressures elevated on prior recordings and might need extra attention and titration of his or her medication. And also those reminders about getting medications refilled or perhaps getting out for the daily walk. We can all benefit from those. Taking advantage of the innovations in care delivery. This is particularly relevant to your work because we want models of care that incorporate the care that you deliver in the home and in the community setting. Making full advantage of our pharmacists, our cardiac rehab teams, you all in home health, as well as health coaches, and even activating the faith-based community to reinforce messages of health, provide avenues for people to exercise, and also feedback on their blood pressure. As you know, there are many new models of care being launched right now, and we're working to get the ABCs embedded in those models and getting high performance associated with incentives, financial incentives. So the higher performance in the ABCs, the better the outcome for the patient, as well as additional credit, reimbursement, or reward for the healthcare professionals. This slide shows you that all the federal agencies across Department of Health and Human Services are deeply engaged in Million Hearts. Each of these agencies, including the EPA and the VA outside the Department of Health and Human Services, have substantive work going on to contribute to preventing heart attack and stroke, and they've dedicated that work to the joint goal of Million Hearts. On this slide are a partial set of our private sector partners. You'll find 5 states that have plans, many health professional schools of every stripe, nursing and pharmacy, dentistry and medicine, public health, as well as a number of community-based organizations. We're really proud that this goal has resonated with so many, and we believe that their contributions are critical to getting to goal. So speaking of getting to goal, you'll see on this slide under baseline the percentage performance rates currently. Under target, you'll see where we want to land by December of 2016. And then the clinical targets are really for those patients who are already in care settings. We're holding them to a little bit higher standard. And you see that's an enormous improvement in a 5-year interval. So we need every one of you engaged in this effort. We are focusing on blood pressure control first, and you see we're going to go from 47% performance to 65% performance over the 5-year time span. And here's why we are focusing on blood pressure control. First of all, many of us, 1 out of 3 of us in the adult population in America has high blood pressure, 1 out of 3. And the bad news is fewer than half of us are under control. For this slide, control is defined as less than 140/90. So those of you who do this care know that's a very generous definition of control. Some people should actually have numbers lower than 140/90. But in this case, even with this generous definition, fewer than half of Americans are under control. On the next slide, we're looking at only those with uncontrolled hypertension. These folks are not under 140/90, and there's 36 million Americans. Out of that 36 million, 14 million don't even recognize that they have high blood pressure. They may have been told, but it didn't stick, or maybe they weren't told. But the data from this survey, which is extremely well grounded and a very valid survey, the Haynes technique, they have multiple elevated pressures and yet no attached diagnosis of hypertension. 14 million people walking around with it and not knowing it. 16 million of that 36 million uncontrolled know they have it, and they're actually taking medication for it, and yet they're still not under 140/90. And when I first saw these numbers, I think I made an assumption that maybe these people were just not seeing doctors or nurses or PAs. They weren't insured, perhaps. But on this slide, you'll see how wrong I was. Out of the 36 million with uncontrolled high blood pressure, 32 million have a usual source of care. 30 million are insured. 14 million of those actually have Medicare coverage. And then out of the 36 million uncontrolled, a little over 25 million have been to their usual source of care twice or more in the previous 12 months. So these people are literally hiding in plain sight. This is a great opportunity to get those blood pressures under control and help these people prevent heart attack and stroke. We know that it doesn't take much improvement in that top number. A drop of only 5 millimeters in the systolic pressure translates to a 14% reduction in stroke mortality, 9% in coronary heart disease mortality, and an overall 7% drop in total death rate. Incredible difference with only 5 millimeters improvement. So our team has done a lot of listening and a lot of observing of high performers in blood pressure control, and we think that if all of the items, all of the bullets on this point, on this slide were provided across the country, we will solve the blood pressure control problem. First is that we need to make everyone aware that these performance gaps exist and what specific actions they can take to close those gaps. We need to equip people with the skills they need to take data and understand what to do, how to turn that around into improved care. The third, and this is one of my favorites, is to blanket the environment in blood pressure monitors. Monitors that are smart enough to assist that individual in getting blood pressure readings back to the treating provider, closing the loop. I think you ought to be able to get gas at the gas station only after entering your blood pressure numbers. You ought to be able to take your blood pressure at the gas station while you're waiting, enter those numbers, and that allows you to pump gas. Same thing with the ATM. No money out until you enter fresh blood pressure numbers. And in that way, each individual begins to own their blood pressure and understand what raises it and lowers it, and really becomes the chief manager for that. We need a standardized protocol so that the work of managing and monitoring blood pressure is distributed across the entire workforce, including the patient and the family. A timely, low-cost loop so that the measurements that are taken in various places around the country get their way back to the treating provider. And that provider is accountable for returning timely treatment advice back to the patient. So again, that's a nice, smooth loop that operates beautifully. Clearly, this is to be delivered by effective teams, and then we obviously need to work on helping people find what they need to stay on their medications. We have a very low adherence to blood pressure medicines over time in this country, and these are major focal points, I think, for your work in helping people understand why it's so important to take their medication, helping them problem solve so they can stay on them. And then finally, we need a business case for this model, which is really transferring control of blood pressure to the individual who has it and supporting them with the professional expertise that you all provide. So we do have a plan. Our plan for blood pressure control is some 140 steps distilled down to the items you see here. We want to do a better job of identifying those with undiagnosed blood pressure, those undetected. Secondly, move those who are being treated into the control group. Make sure we get them under 140/90. Third, as I said, transfer the management primarily to the individual. Who knows their blood pressure best? Well, the individual. Fourth, help to drive measurement and reporting around the country, because we know we only get better and better at those things that we are routinely measuring. And then activate the whole population about choosing lower sodium foods, gradually adjusting our sodium sensor to a lower sodium diet. So one of the ways we're trying to detect the undetected is through this app. It's available free, downloadable from the App Store. It's free until February of next year. It's a great app that allows an individual to do a personalized risk assessment and then locate places in their own geography to get screening of blood pressure and cholesterol. There are also some great educational resources on the app. We're really excited that this is available and hope that you will use it and then help the people that you care for to use it. Secondly, we have a program called Team Up, Pressure Down. This is truly an educational campaign with two target audiences. The first is the general public, to let them know the role of the pharmacist in blood pressure control, working with an extended team, and in med adherence generally. The second target audience for this are actually the pharmacists, and we've provided a number of materials on our website that they can use. A next outlet in terms of really enabling people to be the primary managers of their blood pressure is a program called 100 Congregations for Million Hearts. We know that many faith-based organizations have their own health ministries, and we're asking those health ministries to do at least two of the following of the bullets on this slide. The first and very important one is to designate a Million Hearts advocate within their congregation, synagogue, mosque. That individual can serve as a conduit of information from Million Hearts to that organization, but really more importantly, from that organization back to us to help us understand what materials and services and other things we might help them help provide for them to get help their group get more and more healthy. You see other items here, including use of that Heart Health mobile app. One way to derive measurement and reporting is to recognize the high performers. Last year, we were able to recognize two around the country. The first might not surprise you, Kaiser, Colorado. They've done great work for a long time. The second group might surprise you. Ellsworth Clinic is a clinic in rural Wisconsin, staffed by 2 primary care docs and a physician assistant, as well as a number of nursing staff and additional medical staff. Here in the middle, you see Chris Tashian, one of the primary care docs in the group, and they decided as a team, this is the entire team, that they would get excellent in blood pressure control. This is their secret weapon. Her name is Roseanne. Roseanne reviews a list of hypertensive patients that's generated by their electronic health record every month. And she, on that list are those who are not yet under control, and she calls them, and she problem solves with them, as do other members of their team. Maybe that individual needs to come in for an office visit. Maybe they need to refill their medication. Maybe they need to understand why they're on that medication, or they need to understand more how to take their blood pressure at home and send those measurements in. In any case, this team has achieved a 90% control rate for their entire population of 698 hypertensive people. It's a dramatic result that they achieved. Here are the things that the Ellsworth team does. And I love the third one, the exam room magnet. It's a red magnet that the first person in the office in the encounter who picks up an elevated pressure for a patient tags that patient's chart with this red magnet and goes on the door as the nurse practitioner, or as the PA or doc or nurse go in, alerting everyone to the fact that this person's blood pressure is not safely controlled. Very high tech and very effective. So in terms of the sodium, we have lots of resources on our website, some in Spanish as well, describing ways that people can gradually and safely reduce their sodium intake and therefore impact their blood pressure and, even more importantly, their risk of heart attack and stroke. So we look to the future state. When lower sodium foods are everywhere, our taste buds have adjusted and we actually prefer them. Blood pressure monitoring starts at home and it continues until that individual is safely controlled. Data flows seamlessly between settings, as does advice in a timely way from the source that it's, from which it's most effective. Blood pressure medicines are no copay or low copay because they're actually helping people prevent much more dangerous and disabling and expensive events like heart attack and stroke. And then we finally have the rewards aligned so that high performance on blood pressure control is rewarded for the patient as well as the healthcare professional. And we know this works, as the example shows below. So I'm going to close with just a few asks. Now, these are probably not all, but these are our starting asks for home health care professionals. Can you please prioritize excellence in the ABCs? The most important reason to do so is that we know when control rates for blood pressure and cholesterol and adherence rates for aspirin and the availability of smoking cessation assistance, when all of those are done at high levels, the heart attack and stroke rates fall dramatically and quickly. There's every good clinical reason to focus on excellence in the ABCs, and we'd ask that you start with blood pressure control. Measure the way to outcomes. I believe you all already check blood pressures at every visit. If you don't, I would ask that you do. Help those patients and their family members understand how to self-monitor their blood pressure, how to interpret those numbers, and how to call for help. Reviewing the readings with the patients so they begin to identify their own patterns. I know this may be, I'm preaching to the choir here, but I'm trying to be very specific on what we think will help in blood pressure control. Closing the loop, you all are so beautifully positioned to capture the blood pressure readings that are being taken out in homes and in the field and transmit those data back to the treating provider, the actionable ones. No one needs to receive a list of normal pressures, but when you see a pattern of pressures falling outside that normal range, that is when closing the loop by getting that information back to the treating provider will absolutely result in a better outcome for that individual. Offering guidance about healthy habits and helping problem solve through the obstacles that people face, many of them, and I only listed a subset here, but you are in the homes, so you are best positioned to understand what that individual's specific obstacles are and help them begin the problem-solving process. This last bullet I am extremely sincere about. If you would share with us what has been effective for you in your model of care as you deliver it, and also what doesn't work. We are in a position to collect those lessons and to disseminate them to others so that we can accelerate the learning and get to better outcomes much faster. We have a set of resources on our website. Here's a partial subset. And I'll close by asking each of you to take the pledge on our website. And if you belong to organizations, either in your private life or your professional one, that are not partners, please chat with them about pursuing the partnership option. We would love to have them as full and official partners in the effort. So I will close now, and thank you very much.
And thank you so much for this excellent, informative, and exciting information, Dr. Wright. We are so happy to see such a coordinated effort across the public and private sectors to prevent heart attacks and strokes across the United States. Just a reminder, if any of you participating in today's webinar have any questions, please send them to hhqi@wvmi.org, and we'll get to as many as we can during the Q&A portion of today's webinar. Unfortunately, Dr. Wright has to leave, so she will not be available for the Q&A, but if you have any specific questions for Dr. Wright, please share them with us at hhqi@wvmi.org, and we'll make sure that she receives them. Now to tell you what we at the Home Health Quality Improvement National Campaign will have to offer the nation's home health community to support this cardiovascular health improvement initiative is Eve Eslinger, our lead RN project coordinator for the HHQI National Campaign. Eve?
Thanks, Shannon, and hello, everyone. I'm going to be sharing information on our evidence-based cardiac educational resources. Our resources are designed for home health providers, but I would like everyone to know that they're not exclusive to home care. There certainly are, certainly some of the material is specific to home care. Most, though, can certainly be used by all other care settings as well. To obtain the packages and the resources that I'm going to discuss, you do need to register on our website, homehealthquality.org. Of course, registration is free, but to get a hold of those packages and the resources, you do need to register. So what I'm going to do is give you a little history of our resources for those of you who may not be familiar with our work here at HHQI. The primary educational resource that we've developed over the past few years as part of our ongoing work with the campaigns is the best practice intervention packages. We've developed several packages on topics such as medication management, hospitalization reduction, fall prevention, disease management, and so forth. There's many packages that are available on the website to you. Some of the packages are larger and more comprehensive, and we call those primary packages, and some are briefer or focused. So what we're doing at this point with the incorporation of the cardiovascular focus, we are continuing this familiar pattern of the best practice intervention packages, but we're expanding it to incorporate the goals of the Million Hearts Initiative. So we are going to produce 2 best practice intervention packages on cardiovascular health. These are primary packages, as I just described, the more comprehensive, larger package. You'll see on the screen that these will be released on August 1st, which is next week actually, the first package, Cardiovascular Health Part 1, and then on November 1st, 2013, Cardiovascular Health Part 2. You'll also see the topics for the package that's going to be posted next week. Part 1, we're addressing aspirin as appropriate and blood pressure control. For the November package, Part 2, we're addressing cholesterol management and smoking cessation. I'd like to give you a little idea of what's going to be in the package. There will first be an introduction into the reason for the focus on cardiovascular health and the Million Hearts Initiative. The package is then divided into two parts, as I just mentioned, the aspirin as appropriate and blood pressure control. And these are really, can almost stand alone. They are almost like sub-packages. However, some of the resources in the package really incorporate both topics. For example, at the end of the package, we have clinician tracks, discipline tracks. So there's a nursing and therapy track, which would incorporate both aspirin information and blood pressure control. You'll find many, many tools in the package and on the website. Each package, each best practice intervention package that we've developed over the years, and certainly with these cardiovascular packages, has its own web page. And so you'll find many tools available on that web page as well as in the package. We even have one page devoted to ways to improve staff cardiovascular health. So, you know, looking at improving the staff's health, your clinicians and your other staff, is also an important part of this endeavor. The patient and clinician tools are all evidence-based. We've created some of the tools. Many are from other organizations, such as the Centers for Disease Control and Prevention, National Heart, Lung, and Blood Institute, Agency for Healthcare Research and Quality, and the American Heart Association. We're looking forward to sharing our first cardiovascular health best practice intervention package with everyone next week. And as always, we welcome your comments and input. At this point, I'm going to turn the webinar over to Cindy Sun, who will be discussing measuring cardiac improvement in the home health setting. Cindy?
Thanks, Eve, and hello, everyone. So as we learn about all of these new innovative ways to incorporate cardiovascular health into our patients and get more into a prevention mode and educating our public that we have in the home health, the question is, where do we or how do we go about measuring it? As with all quality improvement, knowing where to focus your efforts is really the first step. So to help with this, HHQI will begin publishing agency-specific cardiovascular reports in August. The reports will provide information as to how at risk your population really is in regards to cardiovascular health. Now, as with all previous HHQI data reports, this data will come from your OASIS transmissions. But as we all realize that the OASIS, although they are great in many ways, or it is great in many ways, it really does not contain cardiovascular prevention care measures. So for this reason, we'll be introducing the HHQI Cardiovascular Data Registry. It's on the right-hand side. And this is it's optional, definitely optional, as with everything HHQI related, but these will be customized cardiovascular data reports demonstrating your agency's improvement in cardiovascular preventative health. It'll be generated using a few pieces of data from your patient's records, such as blood pressures, were they elevated or not, was the patient on aspirin therapy, etc., that level of questions. There's a maximum of 7 questions per patient to be answered, but some will only require 1 or 2 questions to be answered based on skip logic, which is based upon the patient's diagnosis code. Now, the diagnosis code, as well as all demographic information, will be imported from your OASIS, so you don't need to complete any of those questions. Just know that some patients will require very few questions to be completed so that you can create these reports. And we will import as much as we can from the OASIS to save you time. That's the whole goal on this, is to make it as minimal as possible, but yet while providing quality reports to let you know where you stand in trying to increase your cardiovascular prevention. The data collection is going to begin in August, and the first reports will be produced in October. Now, I'm not really going to go into additional details now because I'm sure there's many of you who your eyes have glazed over or glossed over with the sheer mention of data. But if you have any questions, please feel free to contact us for more details. Data is one of my favorite subjects, so we'll talk as long as you want to talk on it. And we really want to encourage you to participate in this so that you can have these reports to not only help utilize them in focusing your QI efforts, but also as an agency, hopefully you'll be able to use these reports in either initiating or continuing the dialogue with your community providers, talking about best practice intervention strategies to create a community focus in encouraging and improving your cardiovascular health. So with that, I will turn this over to Misty Kevich, who will talk about cardiac resources for the underserved population. Misty?
Thanks, Cindy. Well, first, I really want to thank Dr. Wright. She's really presented and painted a picture of issues for the underserved population related to cardiovascular health. But I have a little bit more, some statistics to provide for you to show you that we do have a national problem. The research shows that heart disease affects race and culture, especially with the African American and Hispanics. Our American culture is negatively influencing many cultures with unhealthy diets and sedentary lifestyles, and I think you can see that from some of the slides that Dr. Wright had. Their gender issues occur with cardiovascular health as well. Heart disease is the #1 cause of death in the United States for African Americans, American Indians, Alaska Natives, Hispanics, and white men. It's the 2nd cause of death for Asian and Pacific Islanders. With that, heart disease is the #1 cause for the U.S. women for African American and white women. Heart disease is tied for #1 with Hispanics with cancer, and American Indians and Alaska Natives and Asians are the #2 cause of death. So you can see that consistently we do have an issue with a variety of cultures. Women's risk increase with age due to menopause. So therefore, we find that hormone replacement therapy becomes a factor with postmenopausal women, as well as transsexual females who elect to take hormone therapy. There is an associated risk of increasing cardiovascular complications with the hormone therapy. So not only does race and gender factor in, but also underserved regions in our country affect cardiovascular health. The term stroke belt is used to describe some of the highest risk states for strokes that include Alabama, Arkansas, Georgia, Indiana, Kentucky, Louisiana, Mississippi, North Carolina, South Carolina, Tennessee, and Virginia. Also in a lot of the same regions, but in other pockets in the country, we don't have enough health care services to facilitate the number of people that need providers. And so even the providers that are strapped for time may spend less time on prevention. So I hope that you can start to see with some of the statistics that we really do have our work cut out for the underserved population. Throw in poverty and our dually eligible patients, they're at a higher risk for heart attacks and strokes. And there's many variables that influence that. Maybe functional and health literacy, lack of transportation, non-adherence to meds, which could be for many different reasons, including finances, transportation, even just a lack of self-motivation or not understanding how to even take their medications. So many Americans even lack health insurance, and we know that these people use the emergency room as their primary care services or end up having the heart attack or stroke or actually die before even seeing any type of a primary care provider. So in the HHQI Cardiovascular Health Campaign, we're going to try to support you in addressing some of these issues and giving you education and insight and some tools and resources. There are sections in each of the BPIPs that are going to be released that Eve talked about that cover the underserved population in each of the sections. We also have our underserved population or our UP networking calls. We usually have those twice a month with the exception of the summer and holiday months. And in fact, next month's topic for August the 14th from 3 to 4 is on African Americans and their disparities. And this session is entitled Advancing Health Equity Now, Uniting Our Communities to Bring Health Care Coverage to All. Our presenter is going to be Nadida Amuta, and she is an assistant professor from the Department of Health and Nutritional Services at Montclair State University in New Jersey. Please go to HHQI's website and click on the UP tab to locate the webinar registration. The session will be recorded and posted in our archive section. But there is a link also for the flyer for some of the upcoming topics. We're going to continue to include all of these topics that are related to cardiovascular and intertwine them into all of these calls. We want you to sign up too for the Update, which is our monthly e-newsletter that includes short pieces of information on current research or findings related to underserved topics. Plus it gives you 1 or 2 resources, and we will definitely be covering the cardiovascular in these newsletters. If you're not getting the update, please send us an email at hhqi@wvmi.org. That's hhqi@wvmi.org. And also just watch for our blogs. Sign up to receive the blogs. We do those on a variety of issues, and they do include underserved populations and cardiovascular issues. And the last item is that HHQI team is very happy to assist you with any of your underserved population issues or barriers. So hopefully I've captured some of the many pieces that we're working on related to the underserved population to assist home health agencies to provide better care and outcomes for our patients, and that we can help reduce the deaths and increase knowledge and awareness in our communities. And with that, Shane, I'm going to turn that over to you.
Thank you so much, Misty. Great information, and thank you to all of our presenters for this overview of all of the educational, data, and underserved populations resources that the HHQI National Campaign will be offering starting this summer to help prevent heart attacks and strokes. We now come up to the question and answer portion of today's webinar. If you have questions, please send them to hhqi@wvmi.org. We'll address as many as we can during the duration of the webinar's next 15 to 17 minutes. Our first question we go out to, this comes from Patrick, and this one's directed to Eve Eslinger, and this question asks, says, it's been challenging getting blood pressure parameters from physicians. What do you suggest to improve this important factor to improve self-care management?
Hi, Patrick. I saw your question, and I worked in home care myself for many years, and I couldn't help but think that is absolutely true. It was always difficult to get parameters unless it was a patient that you really had, significant scary hypertension, and of course then we would have parameters. But for most of the patients, it can be difficult, and part of it is the reason we have this Million Hearts initiative is that we just have not been paying attention to hypertension as much as we should have. So, what I think I would do is really address it as you are participating in the Million Hearts initiative, and encourage the physicians that you're working with to do also. And I mean, it would be a very nice letter. You could even ask, say that you're going to be asking for more parameters on the blood pressure. It would be a great, I think, community outreach, but even more so to the health community. I think that would be something certainly that they will not have heard of before, and it would be, help you meet your goal of getting those parameters. That's my thought.
Our next question comes to us from Linda, and this question is directed to Cindy, and it asks, is the cardiovascular data registry collection an audit?
Hi, actually, no. It is pretty close to the furthest thing from an audit, if you would. The only ones who will have access to this will be your agency and who you give permission to view it. The same as the HHQI data reports. All of the reports that you currently have access to, which are your ACH, oral medication improvement, flu, pneumococcal reports, all of those reports, as well as these two new, the data registry and the cardiac risk report card, are all going to be stored into the secure site where only you at the agency will have access to it. Now, if you give access, you hold all the control. If you want to give access to everyone in the world, that is completely your call. The idea is these reports they're your property. All we're doing is creating them and storing them for you. So it really depends on who you give access to, but no one will have access through us other than you. And in fact, if there's no way that we can actually convey agency level information to CMS. Even if you wanted it that way, you would have to do it yourself. So no, this is not only not an audit, these reports are for your eyes only. If you have any other questions though about it and you want to talk one-on-one, feel free to give us a call or contact us and I'll be happy to discuss it further with you. Thank you, Shannon.
You're welcome. We have a very similar question that comes from Melinda, who says, who will have access to these cardiac data reports? And I think your answer covers Melinda's question as well, Cindy. And just to reemphasize what Cindy said, if you would like more one-on-one correspondence about this or information, you can contact us anytime at hhqi@wvmi.org, not just during today's webinar. We'll be happy to provide you more information on the cardiovascular data registry and the new cardiovascular risk report that will be coming soon to HHQI Data Access.
Hi, Shane, and this is Cynthia Pam, and I just wanted to chime in on that whole point. Just reminding you guys, if you dialed in late, I'm from CMS, and no, I do not see this the data. This data is just for you for quality improvement purposes, for your internal use. WVMI does not submit any named data to me. All I get is the fact that the work is getting done, and they aggregate the information for me to show that 1,000 home health agencies did this, that, or whatever the case is. So it's never any named data, just to put your minds at ease.
Thank you, Cynthia. Great point. Our next question comes to us from Melissa, and this one's directed to Misty Kevich. And Melissa's question is, will you be offering specific cardiovascular resources for the African American community?
Oh, that's a great question. We are, and actually we have resources that will come out next week in this package related to aspirin therapy and blood pressure that are related to African Americans and other cultures such as the Hispanics. And we created a new icon. We do have little icons that we use for the underserved population, such as for the dually eligible, for small home health agencies, et cetera, kind of highlighting if you had to pick something, it kind of draws your attention to it. We also added one for multiple languages for the tools. So you'll see that in the introduction and how to use the package, and then you're going to see those beside tools that come in multiple languages. But yes, we do have a variety of resources listed in multiple tables in the packages. But thank you for the good question.
Our next question comes from Tammy, and this one's directed to Eve. Tammy asks, will these cardiovascular best practice intervention packages be the primary or focused version of your HHQI BPIPs?
They'll be primary. They're more comprehensive. The only focused packages that we've released so far with the campaign was a self-management package back in November 2012 and a medication management package in April of 2013. But for the cardiovascular Part 1 and Part 2, August and November, those will be the primary, the more comprehensive packages. Thank you.
Our next question comes from Randy. This one's directed to Cindy. Randy asks, will the HHQI network coordinators be participating in this cardiovascular health improvement initiative?
Oh, that's a very good question. Thank you, Randy. And yes, they will be. The HHQI network coordinators, for those of you that are not familiar, are they're leaders in the campaign, whether they are at a state level, they may be your home health association, possibly your quality improvement organization, maybe you're part of a corporate entity. They're basically leaders who help with working with 11,000 agencies. And yes, the network coordinators have been very active in this already as far as the planning and getting the information out. So yes, continue to talk to your network coordinator, and if you're not familiar with who yours is, it is available on the website listing by state as well as organization. And if you are unable to reach them for any reason, if they're on vacation or anything of that nature, and you have questions, you can always contact us, and we'll be happy to help you with any of this aspect. So thank you for the question. That's a very good one.
Our next question is directed toward Misty Kevich, and this question says, do you have other resources for underserved populations beyond cardiovascular ones? We're really having difficulties with diabetes right now.
Well, thank you. Yes, there are, if you have not downloaded the Underserved Best Practice Package, it's one of those primary packages that Eve talked about. It's really in-depth. It was released in February. It is on the site. You can download it. There are there's a ton of resources that are provided. Some included in the package are related to diabetes, and as well as on their website. Look there and see if you can find anything that would work for you, or contact us if there's something specific that you're having a problem with. Use our HHQI@WVMI.org, and then be very happy to help you find some resources that would meet your needs.
Our next question comes to us from Danielle, and I'll take a stab at answering this one myself. The question from Danielle asks, can you tell me again how it is that we can take the Million Hearts Pledge that Dr. Wright spoke about? That's a simple answer. All you need to do is go to millionhearts.hhs.gov, and on the front page of the Million Hearts website, you can click on the Take the Pledge link, fill out several quick and easy fields, and then you will be demonstrated as an individual or an organization committed to preventing heart attacks and strokes across the United States. Our next question comes from Paul, who asks, should we download and implement both of the cardiovascular best practice intervention packages? And that one's for Eve.
Yes. Short answer.
Shorter is better, so we'll move to the next question that comes from Mike, who was wanting to know if Misty Kevich could share the list of the stroke belt states again.
Oh, absolutely. Let me grab those here for you. That is Alabama, Arkansas, Georgia, Indiana, Kentucky, Louisiana, Mississippi, North Carolina, South Carolina, Tennessee, and Virginia. And if you notice, most of those are in the southern region. And so diet and nutrition really do go hand in hand with cardiovascular risk and sometimes a sedentary lifestyle. And we do know that southern cooking, that's pretty delicious, but a lot of things are fried, even fried pickles. My sister-in-law loves those, and I can't seem to get the taste for them. But there is an association of much higher risk for stroke in that region. And if you need those the names again, it will be in the package under a resource, but just send us an email. We'd be happy to send it to you.
Thank you, Misty. Our next question comes from John, and this one is directed back to Eve. And John is asking, could you tell me again the 2 dates for the cardiovascular best practice intervention packages to be released?
Sure. Next Thursday, August 1st, will be Cardiovascular Health Best Practice Intervention Package 1, focusing on aspirin as appropriate and blood pressure control. So next Thursday. And then November 1st, I don't know the day of the week, but it'll be November 1st, and that will be cholesterol management and smoking cessation.
Our next question is from Joseph, and this one is for Eve or Misty Kevich. And Joseph asks, do you have recent data concerning ASA for people who have not had a cardiac event, and also recommended medication treatment for African Americans related to HTN? Yes, I'll address the second part of the question. I had just sent you a message, Joseph, with chat. I saw your question, and as far as there is very clear medication. In fact, one page in the package deals with the suggested medication schedule for African Americans for hypertension. And I'm going to turn it over to Misty to answer your question about aspirin.
Absolutely. We have the recommendations for aspirin therapy that are included for age groups and the precautions that are all built right into the package in nice little tables that you're going to be able to see. And we also talked about the underserved population issues related to aspirin and the hypertension as well, in addition to the resources for that. So you'll find all that information, and it's all the current evidence-based practice information.
Excellent. We have time for 2 more questions before we wrap up today. This one is for Cindy, and this one comes from Sandy, who asks, are you able to travel to our location for cardiac data abstraction if we cannot send this information electronically?
Hi, Sandy. That's a good question, and actually the larger answer is probably not. What we are doing is a pilot project where we are going to abstract from a geographical convenience sample right around our location. Traveling is not something that we're able to do. But if you would like any assistance with it, or if you have electronic records, I'd be happy to help you get started. We also have chart audit tools, which if you are wanting to go this direction, you can put the chart audit tool in the same as you do with your other audit tools in the beginning of your chart if it's a paper record, and just complete it as you go through as the patient's being cared for. And then upon completion or the discharge of the patient from your agency, then entering the information into the data registry will take you very little time, probably, honestly, maybe 2 minutes to do it once you have the chart audit tool in place. If you have additional questions, though, I would like to talk to you. I'd be happy to talk with you offline. So give me a call and or contact me through HHQI info, and we'll set up a time to talk. And that goes for anyone. Thank you, Shannon.
Our final question comes to us for Stacy, and this leads in perfectly to our next steps on the following slide. And this question is directed to our communications manager, Misty Dyke. And Stacy asks, where can we sign up to be part of the cardiovascular data registry? Misty?
Hi, Stacy. The quickest way to sign up for the Home Health Cardiovascular Data Registry is going to be to visit our website. And the web address there is www.homehealthquality.org. And then the process from there is going to be a little bit different depending on whether or not you're a brand new HHQI participant. So if you're brand new to the HHQI website, you'll need to create a username and password. So once you get to the website, just click on the registration tab in the main navigation. And once you complete and submit the registration form, you'll then be given the option to join the Home Health Cardiovascular Data Registry. It'll be a secondary page that pops up. If you've already created a username and password for accessing the BPIPs on the HHQI website, the process is going to be just a little bit shorter. Once you log into your account, using the login link in the top right corner of the home page, once you're logged in, just mouse over the Members tab and then scroll down and select the Cardiovascular Data Registry page. And that you'll just have to select yes, sign me up, and that'll get you on the list. And also on a side note, if you register or if you sign up for the registry before November 1st, you'll receive a Cardiac Pioneer logo and a press release template that you and your agency can use to promote your support of the Million Hearts Initiative. Thanks, Shannon.
Thank you so much, Misty. And in addition to being able to sign up that way, we will also be automatically directing all of you participating in today's webinar to that sign-up page that Misty had just referenced. So if you're logged in and already a participating member of the HHQI National Campaign and you check that Keep Me Logged In box, you'll be automatically directed to a page to sign up for the Home Health Cardiovascular Data Registry. And as Misty had mentioned, you also get a Cardiovascular Pioneers logo that you can display on your website or in your marketing materials, and a press release template that you can use to tell all of your partners and your community about your commitment to preventing heart attacks and strokes. So please sign up for the Home Health Cardiovascular Data Registry now. That registry will open for inputting of data next month in August, but you can sign up and get your logo and your press release template now. You can also take the Million Hearts Pledge at millionhearts.hhs.gov now. And as Eve mentioned, coming next week on August 1st, we'll have the Aspirin as Appropriate and Blood Pressure Control Best Practice Intervention Package debuting on our website. Last of all, if you missed any of today's presentation and you'd like to join us for an encore webinar broadcast, next Tuesday, July 30th at 3 p.m. Eastern, we'll be offering the same presentation for folks who were not able to join us today. So on behalf of everyone on the Home Health Quality Improvement National Campaign team, I'd like to thank you for joining us for today's webinar broadcast. I hope you have a great afternoon. Goodbye.